So we'll just start with a little bit of an introduction. My name is Carly and I am one of the physiotherapists at Playworks Physio. And we're doing a webinar today with the lovely, amazing Tamara. I'll let you start off if you want to do a bit of your introduction, Tamara, and then I'll go after. Go for it.
Okay, so, welcome. So I'm Tamara, obviously there's Carly, pictures of us. So I'm just quick run through. I've been a physio for almost 15 years. I did my training in Australia, background in psych and kin. I used to be a personal trainer, did a whole ton of extra courses. I worked with teams in my past and athletes, and then started my pelvic health sort of journey / education about 10 years ago now, and I've been treating pelvic health for 10 years. I do still see a lot of everything else as well, because I still love all the ortho manual stuff. And I have 4 kids. So I think I have some great experience with respect to not only pre and postpartum, but kids and pediatrics. And we're a super active family. And the reason I kind of got into this is because my 9-year-old now originally kind of suffered from constipation issues. And so I knew there had to be more to the picture than just sort of laxatives. So I was able to align myself with a phenomenal pediatrician that I work very closely with now, and believes in what I do. And I have had some really awesome mentors as well along the way that have not only encouraged my pelvic health practice, but also my pelvic health practice with respect to pediatrics. So, and then of course I learn from every single patient because everybody's different. And of course now, knowing Carly for the last, year and a half, learn even more because she's deep into the ped stuff. So it's just been great. And so I'm really excited to share information with you guys this evening.
Woohoo.
Carly.
So I'm Carly, everyone. I have been a physio for the last 4 and a bit years, and I did my physio degree back in Ontario and moved out to the West Coast when I finished physio school, and I love it out here. I've been working at Playworks now in Port Moody, and we see everything from tons of athletes, lots of concussion, to kiddos, little babies with plagio and torticollis, all the jazz, kids with developmental delay, and wonderful, all sorts of different diagnoses. So pretty much all kids we see. And why I decided to get into pelvic floor physio, besides having my own issues via athletics and being quite a high level athlete, I started to notice that the more that I actually learned by going to my physio, the more that I learned about how pelvic floor is your central core unit, the more I started to see it as a gap in the treatment that I was providing to my kids. And, I would see treatment not being full circle, coming in a full circle, and seeing kids, that I'd treat for tiptoe walking or for just knee pain and stuff, and realizing that they just were lacking their central stability. And then on top of it, being constipated and having those sorts of things. So I have then gone and taken courses in that, so I can give more full circle care sort of thing. So I'm super excited to be presenting with Tamara tonight, and just letting families know that there is help for these sorts of kiddos out there, because it extends so much more far than reading things on the internet and trying laxatives. Like, sometimes the wrong laxative could be making the problem worse. So just to let you guys know that there is help out there. And when I'm not in the clinic, I'm doing pretty much anything on the mountain. I love to ski, I like to bike, I like to run, I like to hike, I like to swim in the ocean, love all those kinds of things. So the West Coast is keeping me busy. So that's us. I'll just run quickly through today's goals. Basically, we're going to learn what makes up the pelvic floor and the core and how it functions together as one unit. We're going to learn about the different types of incontinence because there's a couple different ones to talk about. And then we're going to talk about how kids can improve their bowel and bladder function and control, and how physio can help and what it actually looks like for kiddos, because it's a little bit different to adult pelvic floor physio. So I'll let Tamara take it away for the next little bit and go for it.
All right. So just to kind of set the tone for the conversation, I just want everybody to be clear that this is not going to provide a treatment plan for your child, or because every child is so individual, and that's the same with all of the adults that I treat. Every adult is so individual, and taking a holistic whole body approach, which is what I do, I find that, you know, there is no recipe per se. So I think it's important to know that although it seems like, you know, there are sort of approaches that seem quite straightforward, often we find that we come to like a bit of a plateau or a stale point with those approaches, and that's because it is a recipe, and that's not essentially going to necessarily work for every child, you know, every single time. So just a little quick sort of segue into what we're going to talk about. So, you know, there's lots of studies that are starting to come into fruition and looking at kids with pelvic floor disorders and constipation and different things. And there's one study that demonstrates that 9.5% of children aged 6 to 13 experience nocturnal enuresis. So this is happening twice as commonly in boys than in girls. And so one of the common causes of that, you know, bedwetting at night is actually constipation. And so, you know, this is something that families struggle with, that, you know, even parents said, oh yeah, I wet the bed till I was, you know, whatever age. And so I think it's important to know that, you know, constipation impacts the pelvic floor. It is a visceral sort of system dysfunction in a way, but it can be a result of many different things. And so it's important to kind of look into what may be creating that issue, for example, specifically with constipation, and then how that may impact the body physically. So one of the systems that can impact is the pelvic floor and the core. So, and I have some imagery later of my actually three-year-old daughter who is going through this right now, and you'll see, you know, real time what that looks like. So the core is a super trendy term. And I think it's important to recognize that it involves everything, literally, from, you know, your breathing tube all the way down to where everything exits. And things that can impact it are from the ground up and from the top down. So we're talking, you know, for example, concussion or, you know, an ankle sprain. So I think it's important to understand that it can be impacted by more than just, you know, things from the inside as well. So if you see this image here, you can see how, you know, the multifidus, so the muscles that run along the spine, the pelvic floor here, the transverse abdominals, so the deep abdominals of the abdominal wall, and the diaphragm. So that is what your canister looks like. So when we speak to the core, we're speaking to every single thing that is involved in here. And all of that is impacted by pressure. And when you have constipation, that increases pressure. So the pelvis. So this is the pelvis, okay? I'm gonna keep this very simple. So bony outlets, of course, differ, and they grow as you age as well. So that's important to note. So then the pelvic floor is not going to look the same necessarily in every single person either. So this is looking down into the pelvic floor. And what I want you to understand is the actions of the pelvic floor. And because we're taking, and it is important to take a whole body approach with this, it's important to know what the impact can be on the floor, and vice versa, what the impact of the floor is on the rest of the body. So essentially, the role of the pelvic floor is support, sphincteric, so closures, and helping with intra-abdominal pressure, bladder control and activity, inhibition, as well as sexual function. So anything from arousal, performance, you know, and, you know, anything with the penis and vagina and clitoris as well. So the pelvic floor has 3 layers. So that's important to know. Everybody thinks it's just one entity in itself. So it has 3 layers from superficial to deep. So superficially, you can see these muscles are more superficial, and then it runs deep. You can actually palpate some of these muscles superficially, and then the second layer you cannot palpate unless you go internal, and the deeper layer you can get to 1 or 2 of the muscles externally as well. So external treatment can actually be indicated in many cases if consent is obtained, to be able to, you know, release these muscles or actually assess function. So we don't do internal exams on children or teens, especially, of course, you know, if they're older teens, we always kind of you know, talk about sexual activity, and if they have been sexually active, then they can potentially consent for a pelvic floor exam. So this is layer 1. I'm not going to get super into it, but this is the superficial layer. You can see all of these muscles encompass this superficial layer, and it does connect to this anus and through the vagina. This is in the female. So these are the muscles. I'm not going to go over it. It's not an anatomy lesson, but I just want you to see what it looks like. And this is in the male. All right. So a little bit different. So then, of course, if you're looking deeper into the support system, you can see, and I want you to see how the rectum, so where you could get constipated and backed up, can impact the pelvic floor. Because if your rectum grows, which is called megarectum, which can exist in children once they've been withholding stool for some time, it can impact the pelvic floor function, all right? So this deepest layer you can see is connected to the hips. So it runs in through the pelvic floor and connects out to the hips as well. So that's important to note, because these layers are continuous from pelvic floor to the hips, which then can impact function all the way down the chain. So pelvic floor is not an on and off button. And I think a lot of people think, oh, well, you know, you connect your pelvic floor, and then when you're, you know, you're not holding your pee, it's off. But that's not the case. Your pelvic floor is more like a dial. So there's slow and fast twitch muscles, and they respond to different situations. And you need to understand that the pelvic floor turns on a little bit. So I'm sitting here, and I'm not being, my body's not requiring, you know, much of myself to kind of sit here. But if someone was to push me, then I need those muscles to right myself. So then the pelvic floor needs to come on a little bit more. So that's important to note, because your pelvic floor function needs that relaxation and that ability to connect. And if you're lacking one or the other, that can be or result in pelvic floor dysfunction. So that can result in more tension, so it's more difficult to eliminate or eliminate entirely. And the you know, the difference to that then would be, then you'd start to lose some sensation in that area, because everything's just holding on so tight, or essentially it's just too much pressure. So you lose that sort of, I guess, feedback. Okay. So in summary, basically there's multiple functional layers. They can be trained, and it does also have that automatic control. So something to highlight just for everyone is that pelvic floor dysfunction is basically divided into these 5 categories. And so anything that falls into the lower urinary tract or the bowel, the vagina. So people actually think the vagina is external, but the vagina is actually the tube internally. Your vulva is that external area. So anything sexual and anything pain related. Okay, so there's multiple different categories, and there's different pelvic floor dysfunctions that fall within those categories. So specifically today, we're going to focus more on these sort of lower urinary tract and bowel dysfunctions, because that's generally what we tend to see in the kids. We can also see pain issues as well, and so that's important to note. So I'm going to pass it over to Carly to continue on a little bit with this conversation.
Perfect. That was awesome. Thank you. And definitely a good foundation for sure. So one of the most, I guess, prominent things to kind of wrap your heads around is that it is super common with kids. 20% of pediatrician visits are for incontinence. And that includes, bowel dysfunction and constipation, which then leads to urinary leaking and things like that, and urgency. And 5% of pediatric office visits also occur for constipation. So making sure that, being aware of this. I was having a chat with a colleague earlier, and she was saying to me, she was like, I don't actually know my child's bowel and bladder habits. Once they turn to a certain age and you're not going with them into the toilet, and, you're not helping them change their clothes in the morning and at night, how do you actually know if this is happening? So things to just, be aware of and start to think about as we talk about it. So the next thing we're going to do is get into the different types of incontinence. So there's two main types. There is continuous incontinence and there's intermittent. So continuous is where you're constantly kind of leaking varied amounts, and this tends to be something that's a bit more neurological based, so it's something that you should probably see your doctor about. Intermittent incontinence is something where you have a discrete amount and it's it's a full episode of bladder leakage. So that can be one of many different things. It can be urge, where you have a sudden, you have to go to the bathroom and you can't make it. It can be stress incontinence. So if you're doing a certain activity, laughing, sneezing, coughing, kicking a soccer ball, jumping on the trampoline, and there's stress onto your system, that can cause, a discrete episode of bladder leakage. And then there's nighttime intermittent incontinence, which is wetting the bed at night. So, and then nighttime is further divided into primary and secondary, because I think a lot of families will ask this when I see them in clinic, and they're like, well, they were dry for a couple of months, or they've been dry for a couple of years, and all of a sudden now they've started to, wet the bed. So that would be secondary. Primary is these kids have never actually attained being dry at night. And we'll talk a little bit later about what's normal and what's not, but this is sort of, this is what to look for. So if you're like me, you'll be shocked to find out that pelvic floor, urinary incontinence, is primarily due to constipation. And I would have never thought that was the case. I'm like, I'm not constipated. It's not a thing. Turns out it's true. So if you think about it, you have everything inside your body, and if your rectum is full, it's going to push on things, and it's also going to stretch those receptors in your body that can sense. So you have, your bladder has all these receptors that when it fills, those sensors get activated and it sends a signal to your brain, I have to pee. But if it's stretched, it's not going to work properly all the time. And then you're all of a sudden going to get one big urge and it's going to be too late. And then, all that kind of stuff. So constipation is a huge culprit. And then as well with that, you can also have difficulties with your pelvic floor. Now, two things typically happen. You can have a pelvic floor that is not strong enough, and it's having a hard time holding all that pee and that poop in. But you can also have, and you especially see this in kids and athletes, you see individuals that their pelvic floor is so tight because they're gripping. And this can often happen from kids that have constipation issues and are constantly having number two leakages and stuff like that. So they're trying to hold everything in so it doesn't happen when they're at school, when they're with their friends, if they have gas, stuff like that, and they're gripping, and then these muscles get tight all the time. And then some other things that lead to pelvic floor dysfunction. Family history is a big one. Life events, if a new sibling is born, or if there's, something happening in the family, divorce, injury, illness. UTIs can lead to pelvic floor dysfunction, as well as too early toilet training. So families that are putting a lot of pressure on their children, I'm sure it's happened. I don't know, Tamara, you can probably talk about this with daycares. That's a big one I get in clinic is, your child has to go to daycare, but they have to be potty trained. So you have to learn this. But if their system isn't developed yet, they won't be able to really sense that properly. So that's something as well that can lead to constipation.
So two quick interesting stories. So one is early potty training. So there is preschools that tend to require your child to be potty trained, and some kids are starting preschool at 3. And, the average age of a potty trained a boy, for example, is often 3 or 4. So, if the child is not ready, right, then forcing that can actually, cause these sort of holding patterns. There's a couple other things too that you can add into that, such as anxiety. So anxiety drives bowel dysfunction as well. It's very common, and in kids, we don't often necessarily think of it as a cause, but it can be. They say your gut is your second brain, or now they're saying even your first brain. So I think that we need to be aware of that, because that is definitely a huge component to the mental health side of it. And then the sensory involvement. So I have a little patient who is going into grade 1, and they're very good friends of ours. And it's interesting because at one point I took care of them for a week, and I'd noticed her bowels, like I'm obsessed with, obviously. I looked at her poop and I'm like, oh my goodness, what is that? And so she also doesn't like certain foods. She doesn't like textures of them. She doesn't like certain feelings of clothing on her body. She doesn't like certain foods touching on the plate. And then, so, I was like, wow, my goodness, I think she's actually constipated, because she was having these episodes of leakage at school occasionally, and she'd, have to take extra clothes. So long story short, abdominal x-ray did obviously identify that she was constipated. Her diet's very poor. So that was that was kind of the road that we had to go down with her. And there is a sensory component. So a lot of the sensory stuff that is impacting her, choices of food and clothes and stuff, is also impacting her pelvic floor and her bowel. So just a couple interesting little...
all related.
Yeah, exactly.
So going back to urinary incontinence, different things to kind of look for is you can have that urgency, like, oh my gosh, I really have to go, I'm not going to make it. Frequency as well. So we'll get into norms later, but going too much in a day, also retenting and holding it in and not going enough in a day, those all turn into patterns of bowel bladder dysfunction. And same thing with fecal. So you can have fecal urgency, where like, yeah, gotta find a bathroom now. Same thing as frequency, going too many times in a week or, a day. And then same thing as retention and withholding for various reasons. Bedwetting is another one as well. And then same thing that happens with retention, those muscles start to hurt and you can get pain. So if these symptoms and conditions go untreated, they can persist into a child's life. And most people don't realize, like, I'm a perfect advocate for this, is as a child and an athlete, I never thought that I had any of these issues. And it didn't necessarily present as pelvic floor pain, but like hip pain and knee pain and things like that. And as Tamara showed earlier, the muscles that support your pelvic floor, one of the layers, also wraps around your hip. So if you're kicking a soccer ball and you're doing all these things and you're having these pains in your groin or your leg or whatever, could be something that then turns into pelvic floor dysfunction later. So one of the big important things we want to touch on is that it's important to find a place that will treat children for pelvic floor dysfunction. And I get this a lot in clinic with just typical things in general with kids. Their bodies are different. If let's say they come in with a knee injury, those ligaments and those structures are going to feel different compared to an adult leg. So same thing, the whole body system, their pelvic floor is different and also needs to be treated quite differently to an adult. And, the language use and, making kids feel comfortable and things like that is important to just consider when thinking about if you want to take your child somewhere. And then here's some fun stuff. So some important things to consider. You are not alone. When I took my pelvic floor pediatric course, it was cool because they kind of said that 2 kids in every classroom at least will have pelvic floor dysfunction. So, if your child's struggling with it, it's important not to make them feel alone. And, you can say, there's probably somebody in your class that's also dealing with this. And it's not, kids don't necessarily want to talk about it. So it's not like you're going to know which kids those are, but they are not alone. It is very common. Another thing, as kind of Tamara and I have touched on, is that it's not the child's fault. The kids can do these gripping patterns or withholding patterns, you know, because they don't really know any better, and just because it's an automatic reflex to kind of do that. And same thing, it's not the parent's fault, you know. So one thing is to kind of leave that shame and blame behind. Another thing too is that gross motor delay can delay the relationship of the pelvic floor muscles and the diaphragm in terms of postural control development. So for kiddos that necessarily didn't crawl or didn't learn how to get into and out of sitting or didn't hit those major milestones in a, you know, in a correct kind of pattern, that can then delay, you know, if you didn't spend time crawling and now you're walking, you might not have an appropriate balance in your system. So you might grip with your pelvic floor, you might grip with your toes and toe walk, but then also try to, you know, hold everything together. So you often see those patterns related when there's gross motor delay. So, you know, cool to take a think about. And then as well, as Tamara touched on earlier, and you'll see in a little bit, that kids with a lot of constipation and their poor little bloated tummies, if you think about it, their tummy's so stuck out, their back muscles grip, it makes it harder for them to turn on those muscles, and then it leads to poor postural development, you know, as they continue to grow up. So it's something that, you know, I mean, as physios, we kind of preach it all the time, the sooner the better, it's easier to treat.
Mm-hmm. Yeah.
So, and then the very last one, I tend to not do it in clinic. I don't know about you, Tamara, but I will try to avoid the word accident at all costs, just because it's negative, and it's, you know, you don't want to say, oh, did you have another accident? You know, it's not their fault, and it's an incident, and it's something, you know, it happened, and let's figure out a reason why and get it sorted, but it's not an accident. It's not a bad thing. So here's a good thing. What is normal? So in the first year, it's normal for infants and little ones to go about 20 times a day to void. As they get older and they start to build their body and their postural control against gravity, you see that number lessen in terms of frequency, but it increases to 4 times in terms of the volume. And then similarly to postural control, because postural control develops at about 13, 14 years of age, 12 years old is about when that's kind of normalized to an adult, and it's about 4 to 6 voids per day. So this is where the abnormal comes in, is anything that's, you know, more than 8 times a day is probably increased frequency. And same thing as decreased frequency is 3 or less a day. So those are kind of a good thing to ballpark. And then in terms of pooping, normal is achieved at around age 4. And the normal, what you should kind of be aiming for, is 4 to 9 BMs per week. And then also, what defines bladder control? And I think we had a couple questions about this even before the webinar, about parents wondering, you know, do we book in? Do we watch this? My child's not yet potty trained, but we're struggling, and all this kind of stuff. So bladder control is basically, kids need to understand and feel that they don't like being wet. If they're wet and they don't realize it, they're not at a point where they're ready to attain bladder control. So kids need to be dry for 2 hours, and they need to recognize that they're wet and they don't like being wet. They also need to be able to indicate that they need to go. That's a big one as well. And then an interesting one that I get a lot of questions about in clinic is daytime dryness comes 10 months before. So before nighttime dryness. So if your child's like, you know, you're kind of in the mix of it, and you're like, oh, they've been dried in the daytime for like 3 months, but we still can't get nighttime, give it some time, it's on its way. So that's a big one as well. Okay, constipation, what it can look like. So toilet refusal because of a painful poop. So often kids will, you know, they'll poop and it won't be comfortable, and it'll hurt. And then that leads to them withholding because they don't want to do it again. And then the longer the poop stays in their rectum, the more water it absorbs, and then it becomes harder, and then it stretches more, and then it hurts more, and then all that, you know, it's just a big downward cycle. So some symptoms of stool retention, you know, big puffy belly, pain with poops, smelly odors, and that includes body odors. Interesting fact I learned with taking my course was that it's not just like poop odors, it's your body having that smell too. I know different with kids, but still. And then same thing, stools that plug the toilet. That's a big one that kids are a little bit constipated. Lack of appetite, having urinary leakage, and then as well as having diarrhea. And sometimes you can have so much solid poop in your rectum that the other poop just floats around it, kind of like, you know, if you have rocks in a jar and then pour water around it, the water will get around it. So diarrhea can actually be a sign of constipation, as much as that might be hard to wrap your head around, but is a sign. And then functional constipation happens quite commonly with children. Lower urinary tract with constipation is about 30 to 50%. So lots of kids. And same thing, you get withholding, the fear, the pain. There's a change in the routine. You know, the kids can't go out with their friends to the same things that they do. They can't, you know, go for overnight sleepovers. That's so common with my kiddos that have encoresis in the nighttime bedwetting, is that they don't want to go over to their friend's house for sleepovers because it's embarrassing and all of that. So it's stuff that can, you know, definitely be sorted. Do you want to take it away, Tamara?
Sure. So the typically like if you're looking at what sort of criteria, there is a diagnosis for constipation. So symptoms have to last more than 3 months, and it has to include you know, less than 3 bowel movements a week, basically hard lumpy stool, straining. It can actually also include the diarrhea, depending on the you know, the other things that are, you know, sort of dictating that constipation. And sometimes that man you'll need to evacuate, and that can be the use of suppositories as well. So functional constipation, the different types. So we got like megarectum. So megarectum is essentially, as you can see, what happens with the rectum. So basically, as you get stool loaded, the rectum starts to bulge and grow. And with that, like Carly had mentioned earlier, you start to lose sensation of what actually, when you actually have to have a bowel movement. And so then it's not so much that they don't want to have a bowel movement, it's just that they're not sensing it necessarily anymore, right? So that can then result in those larger stools. I hear a lot from parents, well, they do take a massive poop. It was so big, it was bigger than mine. And it's like, well, that's actually not normal, right? So that can be one of the reasons why. So the slow transit, so that you can actually have this in it's like a whole system effect. So you get that slow transit of you know, stuff through the whole system, and it can be anywhere in that system. It doesn't necessarily just have to be at the end. So that transit time is slower. You're not getting that same neurological sort of component that's driving the system properly, and that can be a result of some delayed maturation in the system, or also can be related to a lot of that sort of poor trunk control and not crawling and whatnot, because you do need that movement and mobility to be able to sort of facilitate that transiting of stuff. Other things such as genetics, of course, and other related factors. So you've got, with respect to genetics, I just want to touch quickly on this hypermobility and Ehlers-Danlos syndrome stuff. I've seen numerous kids who actually haven't necessarily been diagnosed with that, but the parents have had a lot of symptoms and experiences that relate to both conditions. So hypermobility is different than Ehlers-Danlos syndrome, and they're connective tissue disorders. And so it's important to understand that that can actually be one of the reasons that you are getting constipated. So it's an actual underlying connective tissue issue, which means that you're just more stretchy, right? So there is that higher potential to be you know, susceptible to constipation, for example. Toilet phobias, that's huge in schools and whatnot. So I went into my kids' school and I spoke to the teachers about, you know, toileting in the school and how important it is. And also, you know, having a little system in the classroom where the kids that may be more embarrassed to ask to go to the toilet, they actually have a little signal or something they can put on their desk so that they can get up and go. Because a lot of kids will withhold at school, especially if they have that fear of the toilet. The toilets sometimes in schools are not necessarily the cleanest or up to necessarily the standard of what the kid will sit on. So you have to kind of, approach the teacher and make sure that there is sort of an understanding between the two of you, and there is a plan in place to allow your child to be able to go at school. Behavioral problems, sensory processing stuff. There can be dietary issues. Low physical activity is a big one. And of course, we're seeing that massively, in the population now, with the lack of physical education in schools and all that kind of stuff happening. Developmental delay. So again, just looking at some of these things that can happen. Just in case, toileting is a huge one. So making your kids go before they leave the house just because you're leaving the house can sometimes create those poor habits. Going too much, that urgency, frequency, or actually not going at all. Long trips, of course, holding in long trips because there's nowhere to go. Now, kids have a massive fear a lot of the time of auto flush. My daughter does. And she will not go near a toilet if it auto flushes. And now there's a lot of toilets out in public that auto flush. And then, of course, the issue of rectal and anal fissures, those can develop over time with the hard stools and the sort of elimination of those hard stools. And that's essentially trauma to that, opening, and that can dictate as well, holding patterns, as well as medication. So, and then of course you can see how then your soiling and encoresis, which is involuntary, so the child is not doing that on purpose, can happen as this chronic constipation sort of starts to, get worse and worse and worse. So that is actually very common, and you can start to see either, we call them skid marks on the underwear. So that's why it's important to, check the kids' underwear if you're suspecting something like this. And, or, they can have full accidents as well. Okay. Lots of association of bladder dysfunction with bowel dysfunction. So that is the pushing of the bowel on the bladder. So then that can result in pressure on the bladder. And then that can then obviously result in leakage issues. And we see that very commonly, especially at night. So that high tone pelvic floor, obviously your body doesn't want to eliminate when it shouldn't. So then you start that holding pattern even more so. And then what can happen at night is that you end up totally relaxing through the different stages of sleep. And then the child then, of course, wets themselves because they don't have that sense of control anymore. And there's still that pressure. Then there's, of course, there's the neurological, and then obviously the overactivation and contraction of that external anal sphincter. So encopresis, very common, unfortunately, as the constipation progresses. It is the occurrence of feces in these inappropriate places. So when we say inappropriate places, we just mean like on the underwear, or soiling their pants or whatever. Sometimes, they sense it coming, but they can't hold it. And then sometimes it's completely involuntary and they don't know. The skid marks can be a part of that, but it can also be a part of having a weak internal anal sphincter, which is totally different. And then it can also be a result of the stool remaining after wiping, so not eliminating entirely. And then, of course, with urgency and frequency, so a lot of pressure related issues with the bowel as well. So what's a good poop? I'm obviously obsessed with poop and urinating and all that stuff involved with the pelvic floor. So, and I have this poop chart in my kids' bathroom, and they have known since a very young age what is not a happy poop and what is a happy poop. And they actually come and tell me all the time when they have to poop and what kind of poop they had. And so I think that's actually healthy, and it's a very important conversation to encourage in your household, because it actually indicates the health of the individual as well. So, there is a big stigma, of course, around pelvic floor issues still. We see it I see it significantly still in the pre and postpartum population. Nope, peeing's normal after you have a baby. You wet yourself on the trampoline. Ha ha, we all pee ourselves. It's normal. It's actually not. So the same is related to bowel issues. And I think it's really, really awesome to start the conversation at a young age so the kids understand that what is the norm and what is not the norm, because then they can start to speak to you and let you know, so they're not suffering in silence as well. So this is a great chart to have. So Dr. Hodges is a well-known pediatrician in the United States, and he actually has a website called bedwettingandaccidents.com, I think. And he has these downloadable free resources on his website. He also has written 2 books. So I have the one book. I have 2 of the kid books here. I'll show you one of them. So we've got Bedwetting is No Accidents, and they're really great to have around the house, and I have them obviously in my library, and Jane and the Giant Poop. So, you know, they're great books to have so that your kids can understand, you know, what is happening, and that it's not their fault, and that it, you know, why it's happening. So it's a bit of an anatomy lesson, I guess, for a kid. And then he wrote a book for parents called It's No Accident. And it's excellent because it, you know, this affects families, you know, emotionally as well. And I see that a lot in my practice. And I think it's important to know that you're not alone. The Pooping Unicorn, I'm not going to show you the video, but basically Squatty Potty put out a great video that talks about, very briefly, with a cute little unicorn that's pooping kind of like little ice cream swirls, about the importance of positioning for pooping and peeing. And that obviously is going to help with proper elimination. So for kids, they have to have a stool at their feet, no matter what their height is. We should have one too as adults. And this is a great video to very, very simply explain why, especially with respect to pooping, because of the angle that you need to be at to be able to help release that muscle that also helps release that external sphincter. So a great little resource for you to watch, you know, with your kids, if you're okay watching a unicorn pooping. So these are the resources that I spoke about that are really great and awesome. And of course, you're always more than welcome to reach out if you feel like, you know, you need more resources. Now touching briefly on core training versus core strengthening. So I guess one of the most important things that we want to get across with this is that there is a difference. So core training is sort of retraining, rehabbing that system, whereas the strengthening comes after that. So although you may think, I'm going to let Carly kind of talk a little bit about this as well. You may think that you have a strong core. You actually can, if your pelvic floor is, you know, under pressure because you're constipated, then essentially your core may not actually be functioning appropriately. So it may not be strong. And so then continuing to strengthen in your sport may actually be sort of counterintuitive to, you know, solving the constipation as well. Carly, you want to talk about posture and stuff? Because you talk a lot about that with your kids and whatnot.
Yes, definitely. So one of the things, as kind of that I mentioned before, as kids start to develop, especially if they're constipated, they start to get this big belly that sticks out and it kind of hangs down, which then arches their back and they grip with their back. So that can lead over time, you know, and imagine if a kiddo that starts to be constipated around like 2 and 3, if they stay constipated until they're a teenager, like that's their normal is gonna develop like that. So then that makes, you know, it ties into the whole body system. So that means that your hip flexors, because of that tilt of your body, your hip flexors are going to be tighter. Your glutes are at a huge disadvantage in that position. So say bye to your glute function if that's the case. So it kind of ties into everything. And then, you know, everything is a system. So if your hip flexors are tight, things are going to pull across into your shoulders and your neck and your spine. So it just is sort of your central stability, and it leads so much into your posture. And I mean, I can talk about it for sure. When I go to my physio and she releases me, I like feel like I'm so tall after. I'm like, wow, you can't imagine how much it, you know, ties into everything. Now, one really interesting thing to think about is sort of like a canister. And if you think maybe like a Coke can or a can of pop, when it's working properly and it's a nice normal can, it's one on top of the other, and basically what happens is you have your diaphragm on the top and your pelvic floor on the bottom, and as you work and breathe, it kind of works as a piston to kind of keep everything, you know, aligned and working well. If you imagine that piston and then you crumple the can, you know, when you stand on your empty Coke can and it collapses a little bit, that piston is not going to work well. So then, you know, and this is where I see it all the time in clinic, is the kids that hold their breath, you know, they're lying on the ground. I'm like, okay, let's stand up and play a game. And they go, and they sit up, and you hear them hold their breath. You see them hold their breath. Them holding their breath is a sign that their core and their whole system is not functioning properly, and they're gripping. So, and that's, as you can see in this picture here, you can see that, you know, there's pressure from the top. And then if you think about it, I actually forgot my balloon at the clinic, but if you imagine a balloon that's all blown up, what happens if you imagine the diaphragm at the top and the pelvic floor at the bottom, if it's blown up and sealed, if you squeeze the top of that balloon, the bottom of the balloon is going to descend, and that's your pelvic floor. So if you're squeezing your diaphragm and holding your breath and gripping, there's going to be so much, I love the demo, there's going to be so much pressure on your pelvic floor that it's actually not going to function properly to stabilize your system. And then as a result, you grip with your hamstring or your adductor, your quad, or one of those things to kind of keep your body as stable as it can be.
Yeah, exactly.
Yeah, go for it.
So we're going to skip to this kind of real-time ultrasound stuff. So I use real-time ultrasound in the pediatric patient population. So this is my little ultrasound unit that I use. And then the image actually comes up on my screen. And what it is, it's an awesome biofeedback tool. So I can actually image the pelvic floor, so the bladder, transabdominally, and also in a sagittal image to kind of identify and help the patient, kid, adult, whoever, understand what their pelvic floor is or is not doing. And then also I image the abdominal wall to kind of help them understand whether or not their core is functioning as a whole unit. And it's really actually a wonderful tool, and it provides a lot of learning. So I'm going to show you this because, as you can see, diastasis can exist in children. It is actually normal to exist in children. However, it is not actually normal past a certain age. Now, it can also be present in kids with constipation, and you can see the actual line. You can see on this little guy a little bit of doming in his midline there. Okay, now the doming in the midline is that sort of a DR is a diastasis, and we often talk about it with respect to prenatal and postpartum women, but it can be seen in kids too. And then we can also see it in kids that are quite constipated. And a lot of kids I've seen have been told that they're, you know, overweight or whatnot because they do have that distension of the abdomen as well. And that's actually not true. They may not actually be overweight. It just may be that they have poor core control, and that can be treated. So I'm going to share with you a screen, a picture of, okay, so, okay.
Still see the slide.
I think I have to stop this share and then
there you go.
Bring in the other one.
While she's doing that, I'll just side note, I've seen so many diastasis recti this week in clinic. I don't know, must be a week for it. But kids that I'm treating for, you know, knee pain or whatever, and they come in and it's like, oh, that's quite a significant diastasis. So it's super common in kids. So something that can be treated. So go ahead, Tamara, go for it.
So can you see this picture?
Yes, we can see it now.
This is my daughter, 3 years old. She potty trained herself very early. She has three older siblings rather. And, you know, she didn't want anything to do with diapers anymore. And I have to say she did a beautiful job. But she went to daycare very early on at a year old. And actually, I think that's where, you know, the issues started, because we notice now that she doesn't like public toilets. But anyways, long story short, this is a distended abdomen. Okay. She hadn't pooped all day. And this is common for her. And then we notice when she does poop, it's like, whew, goes straight down. Okay. So what I want to show you is what I do with the kids. So this is an image of her pelvic floor. So transabdominal image. So that is going to be looking down on the, you know, the bladder sort of downwards. Okay. So right here, you can still see her stool. She's actually got stool in her bowels. Okay, so I could tell. And I asked her, did you poop today? No, right? And so I can tell that she's actually still got stool in there, okay? So I'm gonna show you now what the image looks like when Okay. So this is a sagittal image, and this is what it looks like when I asked her to try to stop her pee from coming out, okay? So that's her contraction of her pelvic floor. So she understands at 3 years old what I'm talking about. So to say that kids don't understand what you're talking about is not true. They can actually, eventually, and it's through different cueing and encouragement and, different little kid strategies that we can get them to do that, okay? So this is another image that you can see a video of her learning to contract her pelvic floor, okay? Now, you can see that it's quite flat along here, which actually indicates that there's a bit of tone. And I know that because I've been working with her to help improve the tone in her pelvic floor and relax it so that she can have optimal bowel movements. But this is the kind of strategy, biofeedback, that I use for information for obviously determining the state of the pelvic floor, because you can't see it otherwise because you're not doing an internal in kids, but also to help the kid understand and look, and they love the fact that you can see inside their body. And so it's quite fun to use. And then, so that is an excellent sort of way to sort of work on that sort of biofeedback, with kids. I'm going to just share the other screen again. And so there are other things that can be used as well. So there is, often we do some work with, I guess, I don't really use them, Carly. I don't think you do either, but doing the pasting those little,
this SMG, the electrode. There's some clinics that will use like electrodes that will pick up the muscle activation with that and things like that. So you can, there's a lot of different techniques and things like that. It just depends, how,
what's going on with the kid, really.
Exactly.
Right?
With every story and every child, and also different, you can go and see a couple of different physios and they'll all have their ways that they're most comfortable treating with and what they're comfortable with doing. And none of them is either right or wrong, but it's just different. But at the same time with kids, you can't do internals. So we have other strategies to use in order to assess those and treat those and all that sort of stuff.
Exactly. So a properly trained physio who has education and training with pediatric pelvic floor is somebody that you would want to see for any of your kids, bowel or bladder dysfunction issues. So we can help. So shoot us an email if you have any questions, and hopefully we can help you out.
Yes. And just for anyone that's tuning in from not in this area, in the lower mainland, there are shoot us an email. We can help you find somebody that's appropriately trained. Working in peds is one small niche, but then working in peds pelvic floor is an even smaller niche. So, we can point you in the right direction of somebody in the area or in your area that can help with that, to find an appropriate source for you. But yes, thanks guys for paying attention. I don't know if we have any questions. Meg, I don't know if you, we have a question.
Carol just said she has a question.
Amazing.
Then there's one. Carol, you can type your question in the Q&A box, and then.
Yeah, we're more than happy to answer. If anybody has any questions, please type them away. We can spend the next couple minutes answering your questions and all sorts of things there.
I don't think you guys have real-time ultrasound at your clinic, do you?
Nope, not yet. So there is a clinic around the corner from us that's pelvic floor for adults that's offered to co-treat in terms of getting the, the ultrasound activation on and stuff like that. So there's stuff in the area, and then there's you that we can refer to. So
so with the ultrasound, you have to be quite well trained in it to be able to know as well what you're looking at, and also if you're going to actually determine whether or not the child is stool loaded. So it is also an extra set of training
skills.
that's important as well, because we're not technically allowed to diagnose with real-time ultrasound. It's used as a biofeedback tool, and that's what I tend to use it as. But working with the pediatricians and some of the docs at BC Children's, they like me to be able to kind of show, like, send on the imagery, which I'm okay with as long as they consent to, you know, that.
Absolutely. Tamara, do you want to take Carol? Can you see Carol's question?
Carol. My daughter was dry at daytime for nearly 2 years, but has been having daily accidents.
I like the use of the alternate word. I love it.
So yes, definitely something that physio can help with. Time to potty training reminders. I would say that there's probably something else going on that's causing this. And she's 5 now. Oh, she's 6. Okay. No, she's 5, right? Oh, the doctor did rule out constipation.
She's 5.
So the doctor must have ruled out constipation with an x-ray of the abdomen. No x-ray of the abdomen.
They haven't ruled out constipation. So, yeah. So, yeah, I believe that there's no, yeah. So recommended stool softener, she poops every day. So then
you have to have an x-ray to actually determine if they are stool loaded and constipated. So that is the final determinant if a lot of this is going on. So what I would do is I would basically have her assessed properly by physio. So because then we can kind of help with all the different strategies and kind of dive deeper into the story and whatnot and why this may be happening. Because I have seen a lot of kids like that. And it could be that she's not emptying her bladder properly. It could be so many different other things as well that are all a combination of that sort of constipation thing. There was another question I saw here. How do you treat a distended rectum? So I have treated distended rectum in the past. I am trained in doing the balloon technique. So the balloon technique is done if the child actually cannot sense anything and cannot maintain any bowels. So what it is it's a technique where we use a child-sized catheter, and basically the catheter can be pumped up. So you insert, now this is not done at home. So this is done by somebody trained in doing it. So basically the catheter is inserted rectally, and then it's pumped up to a certain level. And then the training is done to teach the kid so once it's pumped up to a certain level that the child feels it, they go, oh, yep, I feel that, because they'll feel a sense of urgency with that. And then you work on retraining that sensory system internally to develop that re-education of that rectum, essentially.
And I just want to touch on that super quickly. A big component of what I had learned in my course was that kids that have, and adults too, that have a really distended rectum, you can work to get that emptied out, and you can use stool softeners and stuff like that. But think of it as a balloon, right? Mm-hmm. If it's been distended and you let for months or weeks or whatever, and you let all of that poop out, it's still going to be loose and saggy. And your colon is a muscle and your rectum is a muscle. So it will go back with time, but that super distended colon, the second that there's a block up, it's going to refill again. So this is something that I think is super important to touch on when you're looking to get help with pelvic floor, especially constipation things, is that this is something that's going to take time, and it's not going to be you come for, an appointment or 2 and it gets fixed. Like, you'll have to be on top of it for a couple of months to make sure there's no block ups, and to make sure that colon can go back to its normal size to then function normally. So that's something also that's important to touch on as
And
well.
that encompasses the whole treatment. So that's not just the ballooning. That's like all the pelvic floor stuff, the breath work, the release work, the optimization of diet. Like we're talking, it's a big picture thing. And a lot of the GI specialists don't know about like pediatric pelvic floor treatment. So the one that I work with used to be the head of GI at BC Children's, and he believes in it and he's a huge advocate for it. So he tends to refer all the time. And so he's starting to obviously get the word out there. But initially I was the only person for the last 5 years treating pediatric pelvic floor in the lower mainland. So it's just, a lot of the time they just say, oh, just sit and wait. But then you wait those 6 months to a year and nothing's changed. And so then they're like, okay, well, what now? You said it would be better in 6 months to a year. Well, it's not going to be better in 6 months to a year unless there's some integration of something, right? So that's where the this treatment plays a massive role. And I mean, we've been fighting. I'm a part of an advocacy group for pre and postpartum moms advocating for treatment for pelvic floor related stuff. And like, we just keep getting slapped right? Because, the doctors are on board and nurses are on board and whatnot, but it's just like, you continue to try to, encourage, but it's still a stigma. It's still the norm for, things to happen. Accidents happen. They're young. Oh, you're supposed to pee yourself after you have babies. It's the same idea. So it's we're still trying to break down those walls.
For sure. And just to
There's
touch on
quite a few other questions there, ladies. One is, at what age is it a problem for kids to still be wearing pull-ups at night? It's in the Q&A box.
Oh, there's another box. Sorry, I'm looking at the chat box.
I don't have a Q&A. Oh, there we go. I wasn't looking at that either.
Okay.
Nice.
So Restorelax. So Restorelax does work, but it can have its unfortunate side effects as well. So I tend to encourage it alongside physiotherapy treatment. Because you do need, like Carly was saying, you do need to ensure that the child is not chronically constipated and still in that stage when they're when we're trying to support them. It'd be better for them to have bowels that are being regularly optimized and relatively, I guess, cleared out in a way. Pull-ups at night. My 5-year-old still wears pull-ups at night occasionally. So I don't think that there's necessarily an age per se, but I think one of the important things is to support your child and encourage, that it's not his or her fault, and that, it's okay to wear a pull-up at night. It's not a bad thing, because if they wet their bed entirely, that's actually a little bit more emotionally disturbing for them than being in a pull-up in the end. That's what I've noticed, actually. So I think that if you can explain to them and support them in the use of that, and then also proceed with getting treatment, then that all in itself is really helpful and not actually a bad thing. So.
And to also go on with, there was a question with the overnight pulling or pull-ups, as well as what is the age for overnight toilet training? Just as the age, some kids at 2.5 will be potty trained and some kids will be potty trained at 5. It kind of goes, the nighttime dryness goes along with the daytime. So, if you have a 2-year-old or let's say 3 years old, that is dry during the day, and they get their nighttime dryness shortly after that, that's okay. But if you're still 4 and a bit and you're still not quite daytime dry, you shouldn't also expect the nighttime dry. So it's kind of a gray area in terms of a specific answer. It is tagged along with daytime dryness, but also at that, you have to take everything into thought. Like, it has to do with your sensory, there's another question about children with ASD. It has to take into, your body as a whole system to answer those sorts of questions. And then to quickly touch on, Andrea, your question for kiddos with ASD, I was chatting with a nutritionist the other day about the best way to help with these kiddos. And Oftentimes kiddos with ASD can tend to be, have sensory involvement, which means they don't like certain foods. They don't like the feeling of certain things. So helping them, diet is a huge thing, and getting on board with a solid nutritionist that can help you learn how to put healthy food into certain foods that they only like, and how to get that fiber in there is a big thing. And then working with a physio, and same thing with what we spoke about earlier. You want a physio that is comfortable treating ASD, that they can show you tips for improving body awareness and all sorts of things like that. So definitely something you can do for those sorts of kiddos as well. So I don't know if you've seen
the potty trained at 3 and recently starting having pee accidents, very common. No, it's not necessarily a potty regression. It's not necessarily a potty training regression. So it actually can be an indication that there's something that may be causing the leakage or accident or, whatever. And that although he does poop daily, you need to know what is the consistency of the poop, what does it look like? Is there straining with it, all that kind of stuff. So there's a lot of other things that may be indicating why this sort of accidents may have arisen. Also, 5 years old, maybe they're starting kindergarten, I don't know, but that can also breed some anxiety and tension and cause sometimes bladder accidents as well.
Mm-hmm.
I
have a good one. The anonymous attendee, what type of exercises can help kids strengthen their core muscles? That's a fun one. A big thing is often I get this in clinic, like, what do you mean? My kid has such a strong core, like it's super strong. They do crunches, they do sit-ups, they do a plank so well. And it's not necessarily training your abdominal muscles and your crunches and your planks. It's about your whole system. So lots of certain techniques. And again, with kids, you got to make it fun. So breathing, and just getting your whole system firing appropriately first. Not just, core exercises in terms of, if you Google, planks, crunches, twists, all those sorts of things. Breathing is a great place to start, getting your system breathing. But at the same time, you can be breathing up at the top of your chest versus breathing down into your pelvic floor. But that tends to be a good one to start at. So to answer your question.
And then treatment, what does it look like and how long does it take? So that's a pretty loaded question, but I can answer it with a little bit of insight, I think. So when I have a kid come into the office, they often come with their parent. And then essentially we look at how they move. Obviously, we talk about everything. We discuss, what's going on, medical history, everything that comes with a subjective examination, of course. And then, of course, we go into how they move, goals, what they're maybe doing activity-wise. So I want to check out all of that kind of stuff. I check top to bottom, so cranium, thorax, head and neck, where their pelvis is, how they stand on their feet. I also look at, I guess how they breathe and all that kind of stuff. Then what we do is we have a look, I use the real-time ultrasound to assess pelvic floor. We have a look at how their abdominal wall is functioning, both involuntary and voluntary, check for diastasis, look at all that sort of stuff. And then based on what the child's needs are and what we see and all that kind of stuff, moving forward, we develop a treatment plan. Often if I'm working with a child, I will write a report and that will be handed off to the doctor or the pediatrician. And we try to work with them to help with, for example, if there's constipation involved, work with a plan that helps with continuing to ensure that they're emptying properly. We talk about potty strategies, talk about how to implement strategies at the school. I often write a letter to the teacher, like the list can go on and on and on, depending on what the child's needs are. So it's quite extensive. The initial appointment is an hour. And even at that point, sometimes it doesn't, allow for full time. And I have to say, I don't tend to see people on a weekly basis. A lot of it is dedication and devotion to the exercises and whatnot that we give you to work on. So I tend to encourage parents to go away, you know, work at it for a good couple weeks, especially if, you know, there's a dietitian involved or something else. And then we kind of meet back in a couple weeks, reevaluate, and then I don't tend to see people for another 4 to 6. Obviously I keep in contact, but I think I try to encourage, you know, it's expensive. So I try to encourage ways that are going to be conducive to the family and the lifestyle of the family that can be, you know, easily maintained, I guess. Right.
Mm-hmm.
So that's short answer to a long question.
There you go.
Yeah.
And then we have one last question, I guess, in the question and answer box from Kira. A 3.5-year-old boy was fully potty trained at age 3. Recently started having 5p accidents per day. I guess a year and a half later. Doesn't happen with poopy poops daily. Would this be a PT issue or just potty training? Oh, did you?
Yeah, I answered that. Yeah.
There you go. That one we did. I was going to say, sounds like we answered it. So there we go. There you go. So if anyone, what we'll do is we're, you know, past 8:30 now. So if anybody has any questions at all, you'll get our emails in the, you know, email handout that goes out. So shoot us an email. I think Tamara's maybe writing them in there now. So shoot us an email if you have any questions. You can, you know, call us, book online, all that sort of thing. And even, you know, just to answer questions or get more information, we're always here to help point you in the right direction. So yeah, thank you everybody for attending and for
thanks everyone.
Yeah, that was awesome.
All right.
And I love the enthusiasm from a lot of you guys shouting in the thing. Thanks guys. Have a great night.